Very good evening to all of you. Can you hear me clearly?
Yes.
Thank you very much. So, on behalf of Sri Lanka Medical Association, I welcome all of you for this very important discussion that we are having today. The objective of the meeting that we have is, as you all of you know, at the moment the number of patients have gone up, and 247 service also, those who are active at 247, we notice that there are many patients who call 247 service, and sometimes even the symptom profile has changed. A lot of people are getting sore throat and other symptoms, and some symptoms that were commoner previously, they are not seen as common as before. So there's a bit of uncertainty on what to do. Similarly, the number of patients going up, and there are many circulars coming in. So it's very important for all of us to get a very clear idea of what is happening, what's the current situation. And as volunteers in 247, we can do a huge service here, because in the current situation, if we can empower the community and the patients on what to do if they get the symptoms, and what not to do, and what is regarding the testing and also vaccination, if we can give good advices based on the current situation and the science, it would be a huge service, basically the empowerment of the community. To do that, all of us need to have a clear idea of the current situation. So that is why we have called for this meeting, and Dr. Sajith Edirisinghe will be co-hosting with me, and similarly Professor Samath Dharmaratna, who is the president of Sri Lanka Medical Association, will be joining us, and we'll be moderating this discussion. We'll have two rounds. First of all, we'll ask from experienced clinicians, what do they experience, or what do they see as in their clinical practice, if there are any change in symptom profile, and the way patients are presenting, or their clinical progression, are there differences at different levels. So we'll start with that, and second round we will go into frequently asked questions related to vaccination, and also what to do and what not to do if you get the symptoms or if you get the illness. Okay, and then frequently asked questions related to testing as well as vaccination. So that's how we are planning to have this discussion. Okay, so we'll start this discussion regarding our experience regarding at different practices. That would be the starting point. First, I would like to ask Dr. B.J.C. Pereira to tell about what he thinks about, what is his experience regarding children, because this time we notice a lot of children are also getting infected. Yeah, so I mean, is there an increase in number, or is there a change in symptom profile, and is there a change in how the disease progresses? So we'll start with Dr. B.J.C. Pereira, and then we'll move into other experienced clinicians. We have Dr. Mahendra Ekanayaka with us, and we have Dr. Shirani Chandrasiri, we have Dr. Asha Samaranayaka, and Dr. Anthony Mendis will be joining soon, and we have invited Dr. Anand Vijay Vikram also, but he may be busy at the moment, and Professor Neeli Kamalavigi is also expected to join us. So first we'll ask from the clinicians, what is your experience? With each clinician taking about 5 minutes to describe what they experience in their practice. We'll be starting with Dr. B.J.C. Pereira. Over to you, sir.
Thank you very much. Indika, can you hear me quite clearly?
Very clear, sir. Thank you.
Okay. Thank you very much. It's such a pleasure to be a part of this discussion. All that I'm going to tell you is actually what I have gathered from my colleagues in the National Health Service, because as for me, I have seen only very few patients with the latest sort of outbreak of COVID. There has definitely been an increase in the number of admissions who have come and got admitted to Lady Ridgeway Hospital. For some reason, I think now more patients seem to be coming to Lady Ridgeway Hospital than to many of the other hospitals in and around Colombo, including the IDH. I don't really know the exact situation in IDH. I couldn't actually find that out, but definitely I have some information from LRH. There are the increase in the sense that the recent numbers have gone up to admissions, something around 20 per day. But the problem really is that many of these children are really not ill. They are positive, but they are not ill. They are either very mildly affected, or they are not even having any kind of major manifestations which should need basically inpatient treatment. But I think what has happened is that the parents are panicking, and also that some of these children, they have been detected as a result of spread through the schools or from the schools, because there are one or two maybe children who were found to have symptoms and been positive, and then others also go and get tested, and the moment they are tested positive, even if they are asymptomatic or they have only very mild symptoms, that they are brought to the Lady Ridgeway, and the general administrative decision, it appears, they are at most of the government hospitals, including the LRH, is that they are admitted. And when I spoke to some of my colleagues, they said that a vast majority of these children basically are not very ill and could really have been managed at home, especially with the facilities that we have from the 247, where we can keep an eye on things that are going on. So that is one thing that that we are seeing. So when you say that there are increased numbers of admissions to LRH, I think it may mean that it also might be a reflection of what is going on in at least some of the other hospitals, especially those outside Colombo. We don't have real definite, because we haven't had time to actually check on this. The second problem, as we see it, is that that now the new waves of different forms of administering the Pfizer vaccine have been instituted for children, and now the latest one is that those over 12 have been roped in to be given the vaccine, and they are given at the moment only one dose of the vaccine, whereas even the bigger children who are kind of over 16 and in the higher classes, they have been given one, and now I think they are suggesting that they be given a second dose as well. So these are the things that, I mean, that will come to pass as we go along, and probably we need to concentrate on this. We, as far as I can see, and what my colleagues tell me from LRH, is that they have so far not seen the other complications that we are a little bit concerned about with the COVID strain itself, such as MIS-C, the multi-system inflammatory syndrome, that has come in. But then our experience with the previous peaks have been that this particular problem tends to surface maybe about 2 to 4 weeks after the peak is reached. So we still have time, because when we get cases of MIS-C, that we will definitely need the facilities of the intensive care units, high dependency units for that, because that is something that can be treated quite well. And at the moment, what they tell me is that the LRH ICU is not really inundated, but there are at least 2 or 3 wards which are taking COVID children, and they are kind of filling up, and I think they are probably thinking now of sending some of those children, especially to prevent the services being inundated, on home care. So that is really the situation at the moment. So basically the symptoms are mild, and there is increasing spread, obviously, because that is why the numbers are going up. But it is seems to be mild in children, and quite a significant proportion are probably asymptomatic, which we really even don't know about, especially from the schools where it would have spread, that that if they don't have symptoms, we don't really know. So the situation is kind of a little bit fluid at the moment as far as children go. But it is not it has not got on to a stage where there are grave concerns about the safety of children. So thank you very much. I think I have said enough. Indigo, over to you.
Yeah, thank you, sir. Thank you very much for that introduction. So now we know we have a basic idea about our pediatric population, about this new coming up cases. Now, since we have the number of cases are going up, but the complications are less, especially the multi-system involvements. And so the vaccination is going on, the progress there. So for our discussion, I would like to now invite Dr. Mahendra Ekanayaka, who has been involved with 247 from the beginning, from the first wave also, with the SLMA 247 service. So he's been a major pillar behind this SLMA 247 telemedicine services. So now I would like to invite him to share his experience with the forum. Over to you, sir.
Good afternoon, everybody. Myself and colleagues and special thanks to Dr. Indika and 247 and SLMA for conducting, for taking this COVID management to the community level and helping the nation in a big way.
Mahendra, we can't hear you very well. I think maybe you are a little bit, yeah. Maybe.
Yeah, I am on my phone.
That's fine. That's fine. I think we can hear you well now.
It's fine.
Okay,
Yeah.
right.
Thank you.
I try to. Yeah. So first of all, I would like to congratulate 247 and SLMA and everybody, especially Prof. Indika and everybody, and I'm very much thankful to all of you all for giving me this opportunity to share my little experience that I have had during past few months. Is it possible to share a small slide with you all, sir?
Please go ahead. You can share slides.
Yeah, just to give you a I don't know whether my just to give but anyway, so this is basically the data that I want to share with you. Is the RAC positivity and admission data from basically from the other hospital during past few weeks. I'll read it out to you already. Basically, from January 1st onwards, we have done 401 rapid antigen tests, and out of that, 126 were positive. And mind you, the test that we did during last 1 or 2 weeks became more than 50% positive. And when you get the breakdown of their vaccination status, out of that 401, there were 261 first dose only vaccinated people. Second dose only, there were 256, and booster 67, right? So, so total number is comes to around 527. So out of that, among the first dose vaccinators, 102 became positive, and among the second dose vaccinators, 82 became positive, and among the 3 doses, that means including the booster dose, only 12 became positive. Right. So, so out of 67, only 12 became positive. So there's a drastic reduction of positivity among the booster dose. So there's no doubt about it. So, mind you that these are the patients who have had concerns and who have had fever, cough, or shortness, any concern, and who have self-presented to to the hospital. Basically, I'm referring to the data on the Vaccine hospital these days. During the first 2 weeks of January, we didn't have much of admissions. Even though the patients who are coming for admission, we have my symptoms correctly pointed out by Dr. BJC Pereira, sir. So, but during the last 1 or 2 weeks, there were a lot of patients came with fever, cough, and shortness of breath. I mean, so at the moment there are nearly 40 to 40 patients inside the ward, but only 2 patients are needing oxygen. And mind you, there is also very small amount of oxygen. So again, the meaning that this time what we are seeing is that the disease severity is very much less, and the patients, the 2 patients who are on oxygen, again they have only got their 2 Sinopharm vaccines completed, and last dose is more than 6 months ago. So last they have vaccinated, they have got their last vaccine now.
Mahendra, if I may interrupt, many have said that they can't actually hear you.
Sorry, sir. Yeah, again, sorry. Yeah, my
Now
phone.
it's better. Yeah, again.
So again, sorry, sir. So again, among the 40 admissions, only 2 patients are on oxygen, and both of them they have got their second dose of Sinopharm 6 months ago. Meaning, so when I went in there, there were no patients who has had a booster dose got admitted. So there's a clear benefit of the booster dose in the symptom profile as well, and the number of admissions are very much less among the booster dose people who have got booster dose as well. So and the other thing is that the symptom profile, when you say again same like but still we don't know whether this is well, by going by the records and the trends, we know that this maybe most of the time is due to Omicron. But when you see the WHO and CDC latest reports, they still say that Delta is also not out. So we don't know, because since we do not have, genetic analysis on each and every patient, I don't know whether these 2 patients who are on oxygen is Omicron or Delta, but clearly they are under-vaccinated. And we had one patient who came with a saturation of 85, and again he was under-vaccinated, 2 doses given, and 3-4 months ago. Right. And when you think of the symptom profile, this time everybody, I mean, unfortunately, we have a mixed bag these days. Any viral upper respiratory tract infection, like fever, cough, and that sort of symptoms, can be anything, right? Maybe sometimes maybe a dengue, maybe any other viral illness, and so unfortunately, all the patients who are coming to the hospital is getting a requested test because of very reasons, but they don't necessarily need that because they are not that severely ill. But patients who are admitting is mainly because their complaint is not even the fever. They say that that they have this mild exertional shortness of breath, like that, or maybe sometimes that these like symptoms sometimes they have, and of course myalgia and fever and that sort of thing. So out of those symptomatic patients, even with what we have, even among the admitted patients, what we saw is that even though they got admitted, within 1 or 2 days, their symptoms disappear. So by day 7, they are ready to go live. And because we do this saturation test, each and every patient every day, but only 2 patients got positive, and one was referred from Rajagiriya after the saturation test was positive. So only those who needed actually hospital in-house treatment. The meaning, I think we need to go for the red flag symptoms And we will, I think we can discuss the approach later. I think that is basically, I think what I have to say regarding the symptom profile and the disease variation at the moment. So, yeah, thank you. Over.
Thank you, Dr. Mahendra Kanayaka. So the basic essence of your message is at the moment, most patient who get critical or oxygen dependent are not the ones who has completed the vaccination, and those who haven't got the full vaccination, they are at higher risk. So now we'll move into the next presenter, that's Dr. Shirani Chandrasiri, who is a consultant virologist and past president of the Sri Lanka College of Microbiologists. So she will tell us what's the current situation regarding the patient profile that we are seeing, and then maybe the test positivity and probably the limitation that we are having at the moment also. Over to you, Dr. Shiran Chandrasiri. Meanwhile, can I ask from the participants, all other participants, to mute their microphones apart from the speaker? Okay, yeah, over to you, Dr. Chandrasiri. Shirani, over to you.
Good evening. Thank you, Indika. Only I need to correct one thing. I'm not a virologist. I'm a microbiologist. What I talk about as my experience is limited to one center. So what I say as the positivity is for Colombo South Teaching Hospital. Till last week we had noticed the increase. Before that, our PCR positivity rate was less than 10%, rarely going over 10%. But last week, our positivity came to 20%. Now, this week, we are seeing over 20% positivity rate. So, simply 1 in 4 positive in our PCR runs. Rapid antigen is little less than that, but it's also around 18%, 20%. So case number is going up. I agree with Mahendra that patient clinical symptom severity is not like when we had Delta. What I see in HTU are mainly oxygen dependent patients are either not vaccinated or single dose of vaccine. Those who are complete course of vaccination, that means 2 doses and single booster dose, very rarely we see in the HTU. Even if they come, they go like in 2 or 3 days back to the wards. They are not oxygen dependent. We keep them under observation, but not very bad. But I want to stress on 2 things. In 2020 and 2021, we did not see flu. So when patients came with fever, it was almost like corona. But now the problem is we have dengue running, we have flu patients also. So this is a scenario common to the whole world. Even other countries did not see flu much during the past 2 years, but this year they are talking about flu-rona, that is corona and influenza together. But our problem is when the patient comes, we don't know whether the patient is having dengue, influenza, or corona. So it's important if the patient is not improving to check about other, because we are having home care patients. If one person is positive in the home, they are not interested in coming to hospitals to get tested. So if the patient is not improving, they need to check these other problems like dengue. That is very important. I want to stress. And for the vaccination, Mahendra and I all both insisted on the better outcome with vaccination. So at the moment, all the hospitals and vaccination centers are offering the booster dose, but acceptance is less now. But with this increased number of caseload, now we are seeing this week more and more people coming for their booster dose, which is a good sign. So what I want is all of us need to encourage them to come and get the booster dose. Thank you. I think I have made clear about our experience in Colombo South.
Yeah, and thank you, Dr. Shirani. I think you have very clearly highlighted the increase in number of patients and also the increase in test positivity. And very important message, now we have moved into a syndromic-like situation where the dengue as well as COVID as well as influenza coexisting. And that, like you very clearly mentioned, that would have very clear implications on how we provide support to the patients who are called in 247 service, because it has become the main service that the patient can access while at home. So I think a lot of decisions will have to be based on this situation that you mentioned, that the syndromic coexistence. Yeah. Thank you very much. And before we move to the next presenter, Dr. BJC Pereira want to make a comment. Over to you, sir.
Yes, Indika, thank you very much. It's a very short one. One thing I should say now, I totally agree with Shirani and Mahendra on all that they have said. But something that my colleagues in LRH told me, I think is relevant at this stage, because they have had a few cases of combination of dengue and COVID in the patient. And those children, what they said was that that they have a more pronounced and more severe leaking phase of dengue than in the general sort of lot of children that we get without COVID, those who have only dengue. So I think that is important to be kept in mind now, because if you have a combination of both COVID and dengue occurring in a child, we have so far done very well with the management of dengue per se and the leaking phase in pediatrics. I think that you have to keep in mind that those children might have a more severe form of dengue, in the sense that it might mean more severe or more prolonged leaking phase. So I think this will have to be kept in mind. Thank you very much.
Yes, we saw in adults also the same picture.
Thank you, sir. So, yeah, Dr. Sajid, would you like to take over and then introduce the next speaker?
Yes, sir. So now next we have Dr. Ranmali Samarnayaka, who's a respiratory physician who is very actively engaged in managing the COVID-19 patients. Over to you, madam. Dr. Ranmali Samarnayak, madam.
Her mic is switched off, I think.
Okay, sorry about this. Thank you very much for the kind introduction and inviting me to this discussion. As Professor Indika asked me, what is my experience in managing current COVID situation? I have to say that as a respiratory physician, as a team of respiratory physicians, currently we manage acutely critically ill patients who need basically oxygen dependent patients. From the beginning, I have to say that number is very significantly reduced from what we saw in August, September, critical COVID third wave. And also same impression as Madam Chandrasiri and the VP from Homagama mentioned, Dr. Mahendra, that oxygen-dependent patients are very few, and if they needed oxygen with COVID pneumonia, very few severe COVID pneumonias we see still, and that is due to unvaccination or incomplete vaccination. I mean, after second booster, some haven't taken the third booster, the Pfizer vaccine. So there are few patients like that who got critically ill, but the people who got vaccinated are very few in the ICU. And I have to say that though that is the scenario, the high risk group of cohort, that is with organ transplants, especially renal transplants, people with poorly controlled diabetes, they are having some complications of COVID, not COVID pneumonia per se, but other diseases like MIs and myocarditis. And also I have to say that we are seeing few patients with myocarditis also which needed oxygen in the critical phase. And above all, I have to say that the biggest issue we were facing in the management of critically ill Delta strain was that there was a thing called hyperimmune phase where patients may have mild disease at the beginning, even for first 2 weeks. Then close to the third week, some have seen, some showed severe COVID pneumonia. That scenario is not seen still. I may be too, it may be too premature to declare as such because we are at the beginning of fourth wave. However, we are still not seeing such crisis with this current strain.
Thank you very much, Dr. Anmali. Again, the message is very clear that the numbers are increasing, and even though the number of patients who get critical are not very high, there are some patients, and again the loud and clear message is many haven't got the third dose or the booster. And now let's see the experience of the level where the patient get critical, because even though the numbers may be less, still there are patients who are getting critical. So let's ask Dr. Anthony Mendes, who is an intensivist with a lot of experience in managing COVID patients at critical care, to share his experience, what kind of profile that you are getting there and the numbers, so on and so forth. Dr. Anthony Mendes, over to you.
All right. Good evening. Can you hear me?
Very clear. Yeah. Thank you. Please go ahead.
Yes. I don't actually this. I don't want to talk a lot, but it's very briefly. At the beginning of this COVID, we have seen patients were dying only with COVID pneumonia, without any other comorbidities. But it's in the last few months, we saw this with the Delta variant. We didn't have time to treat the patients. Patients were going to COVID pneumonia and dying. Sometimes one dose of vaccination or no vaccination. Very rarely with 2 doses of vaccination. Those patients also sometimes just after the second dose, like. But in the recent past, last 2-3 weeks, about in last month, I haven't seen any COVID patients dying with COVID pneumonia alone, because and in almost all are vaccinated at least 2 doses. And then anyway, our ICUs are full, but I have only 1 patient with severe COVID pneumonia, but we were able to wean from the oxygen very nicely, gradually. That patient is also very stable, and we should be able to discharge within next couple of days. And then still we are getting unvaccinated patients. One unvaccinated patient is still in the ICU, and this patient is having severe COVID pneumonia, ventilated. So this the chances of the mortality is very high. Chances of saving her life is very limited, and so what I have to tell is even if you all are vaccinated full, even with the COVID pneumonia, you don't die. Even this virus, this COVID virus alone cannot kill patients with COVID pneumonia. That's the message I have to tell. Thank you.
Thank you, Dr. Anthony Mendis, for sharing again the same message, I think, being highlighted, the value of the vaccination and also the booster. Now we have Professor Neelika Malavigi, who has done pioneering work related to identification and sequencing of strains as well. Neelika, would you like to share your experience related to your laboratory findings and also the importance of vaccination and booster? Over to you, Professor Neelika.
Yeah, thank you. Thank you for inviting me to talk here. Actually, our sequencing report today also we released a new one, and so at least in the Western province and predominant in the Colombo area, it is Omicron. So I believe that is good news. The good news is that it causes less severe disease compared to Delta, as everybody has been highlighting. But the bad news is that it spreads so much faster than Delta. And also, it can infect people who have had vaccines. So I think the argument that some people have been putting forward is, what's the point of getting vaccines or getting a booster? Because with Omicron, you can still get infected. So these vaccines are useless. But if we actually pause for a moment and think back at December 2019, when COVID first emerged, if we saw a report from China saying that people got a common cold and fever and a few people were hospitalized, nobody would even, I mean, that won't be news in any country. So the only reason that COVID made news and a pandemic was declared is because of the hospitalizations, severe disease and death. So it is very clear that vaccines, whether it's Omicron or whatever variant, that they very significantly reduce hospitalizations and death. So if I can just give a bit of statistics, with 2 doses of the vaccine in all age groups, it prevents hospitalization by 50%. So which means 50% of people who get Omicron will still be hospitalized. And hospitalization is not a pleasant thing. But if the booster is given, the hospitalization rate reduces by 90%. I think that's a very, very significant proportion. So a lot of people are worried that when they get the Pfizer vaccine, they feel uncomfortable. Some people develop fever. And so some people get very, might feel too tired to engage in their normal activities for like a day. So I think that is not a big issue when you compare in getting hospitalized. Nobody wants to get hospitalized. So 90% prevention of hospitalization is significant when we know that Omicron is transmitting. And when we had the Delta outbreak from July to say early October, we know that even with a lockdown, how many people were infected with Delta. Now, when everything is back to normal, and when Omicron is far more transmissible than Delta, it means that a very large proportion of individuals will get infected irrespective of all the control measures and wearing masks and all those things. So I think in this context, it sounds really strange of people not taking the booster, knowing that there's a very high risk of getting infected. And when the boosters provide such a huge protection. So, so that's all I want to say. But if there are any questions about, because there are a lot of myths that this Pfizer vaccine, the booster causes heart disease and death, impotence, and if there are any issues about that, I'm happy to talk about that also. But I think I would like to stop there. Thank you.
Thank you very much, Anilika, for that valuable inputs. And again, we are highlighting the message very strongly, the why the booster is very much required at this moment. I'm sure there will be a lot of frequently asked questions regarding the vaccination, and also the current guideline was changed yesterday, so changed. So there will be a lot of questions. Let's discuss them in the frequently asked questions section. To end this session, I would like to invite Dr. Sajid to invite the next speaker. Sajid, over to you.
Thank you, sir. Next, I would like to invite Dr. Kalyani Guruge, who's a very well-experienced pediatrician and the highest call answering rate owner of Doc 247, SLMA Doc Call 247. So, madam, over to you to share your experience.
Thank you, Sarif. Thank you for that comment. That is something I should get a award for that. I'll speak on my personal experience first, because when I see patients and order the rapid antigen test, I find that the parents are not doing it, because next time they come and say the symptoms disappeared within 24 hours. So these are very mild symptoms, as all of you explained. They are not lasting over 24 to 48 hours, and they are just fever or sore throat, a very mild sore throat, and maybe a diarrhea. That's all. It does not get complicated more than that. In the 247 experience, it's the same. Almost all of them, the children, I'm talking about the children, the adults also similar experience. The children, all of them, sometimes it is the child who gets the infection first in the family. And according to their, whatever this thing they say, the symptoms have disappeared within 24 to 48 hours. So it is, I think, almost universal experience at the moment. The only sad thing I have to say is that it's not a lot, but people have not got their second vaccine also. The adults, there are still adults who are not getting their second vaccine. I'm not talking about the booster. They haven't got their second vaccine. The children are getting, they are very enthusiastic in giving the vaccine to children. They always call and ask whether it's okay, the symptoms are there. And as in any other condition, the children who need the vaccine are not getting the vaccine. The last call I got was of a patient who had a chronic a premature baby who had chronic respiratory problems. The mother has not gone for the vaccination because she thought it is not good. Over to you, Sajid.
Yeah, thank you very much, madam, for sharing the valuable experience. So I think everything comes together towards a rather clearer kind of pattern or the observation. Even though it may be too early to predict anything, we are observing a clear pattern at this moment. So with all this, what should we do? I mean, what should be, as a 247, we have a huge role here in empowering the patients and community, telling the correct thing, because people are very confused at the moment, and there are a lot of misinformation coming together, and also information is also coming at very fast rate, a lot of circulars being released, and at the moment it's a kind of unclear situation for everyone. So we have a huge role here, and based on this experience and based on the science, based on the available evidence, what should be the advice that we should be giving? First of all, I would like to ask from Dr. Mahendra Ekanayaka, because actually Dr. Mahendra was one person who has been helping us to work out the concept that we have been highlighting in the 247 service, the very simple principle of early detection and the rest in hydration, nutrition, and also detecting early detection of hypoxia and early referral. Those are the guiding principles that we have been working on. So, Dr. Mahendra and everyone, we have been now talking about this syndromic situation where the influenza existing and dengue and also the COVID. and also mild symptoms, the change in symptom profile, at the same time the challenge of not having enough test kits, and people are very reluctant to get tested in this situation. Still the basics remain. I would like to ask from Dr. Mahendra Ekanayaka, what should be our basic principles of management, the guiding principles here for 247? Over to you.
Thank you very much, sir. Again, so I want to stress that, so we should take this as, complex, I mean, viral, cluster of viral diseases like dengue, as Chirani madam said, type, COVID, and that sort of thing. So when a patient comes to a OPD, or when they call the 247, basically what they will be complaining is either fever, cough, maybe viral prodrome or myalgia and other usual.
Sorry about disturbance, Dr. Mahendra. Dr. Chetana Pemasiri, can you unmute and can you mute your microphone? It's not, the sounds are coming, background sounds are coming. Sorry, Dr. Mahendra, over to you.
Yes, again, this, I mean, if he approaches as a viral febrile illness with upper respiratory and exertional or sort of shortness of breath, that sort of symptoms, when you see that, think of the differential diagnosis, COVID is number one. Again, dengue is there, and other viral influenza type syndromes also there, and lepto and other things are also there. So when a patient approaches you, I think this is what we are practicing at Vater and in our practice. So the main thing, during the first 3-4 days, we need to treat them as a viral illness. So same dengue guidelines also we should not forget. So if the fever is persisting more than 3 days, you need to get a full blood count. And dengue testing and other testing is also there, that we should not forget. But now, when the numbers are coming, becoming more, so there's a chance of the hospitals are getting more patients. So then we have to go to identify, we should be able to identify the red flag. So having fever is alone may not be a red flag, but meaning there could be other overlapping diseases as well. The second, when you think of COVID, so what we have seen in the patients is that there's a cluster of symptoms, usually fever, cough, shortness of breath, and especially there is a myalgia and some malaise like body aches and pains are there. Plus exertional short, they can't explain why they are short of breath. I mean, sometimes initially what they say is that they feel like some tight chest like feeling, and then they can't do usual day-to-day activities without getting some difficulty, tightness inside their chest. So that sort of a symptoms, if anybody is complaining, I mean, not many people. I mean, mind you, now if you screen 100 patients, these symptoms may be like cough and exertional shortness of breath. Maybe they are in 5 to 10% of people, right? But cough may be more, but this exertional shortness of breath like symptoms. So those patients, I think need a further evaluation. Either you need to refer them to a hospital, and the people who are having fever for more than 3 days, according to the dengue guideline, we should the dengue is also increasing. We need to evaluate them, and in the hospital setup, or if the patient is having a pulse oximeter. So out of the patients who have got admitted to my hospital, so only we had 4 patients who were desaturation. Maybe out of 100 patients, only 4 patients. This is from Vathara data and one patient admitted with a saturation of 85. And again, he was 2 doses vaccinated, but second dose was, he has got second dose more than 3 months ago. And he was a 65-year-old patient, and he came with saturation of 85, shortness of breath, restless, agitated, and on top of that, he threw up a MI. So he had ST dips, and his troponin was more than 5. So that patient, that is one patient. And there was another VIP patient came, while they had to transfer to IDA. If Anand is joining, I think he'll be remembering. So this patient, he had upper respiratory and lower respiratory symptoms. Again, 2 doses vaccinated, but his saturation was 99 on the ETU, and he was not because he was a little old patient and he was big made. He couldn't do the desaturation. He was not willing to do the desaturation test in the ETU, so we couldn't perform. But his resting saturation was 99. So my main message is that, you know, if the patient is complaining of exertional shortness of breath, and if the symptom profile fits in with you know, if they have left 3-4 days after getting the first symptom, fever, cough, shortness of breath, we need to somehow keep them under observation for desaturation. So what happened to this patient was that, you know, we admitted him, and he had to walk only maybe 20 yards to get to the lift and go to the ward. So the moment he was able to walk, and the moment he went to the ward, my medical officer was very vigilant. They put the pulse oximeter, and they saw that his saturation has dropped to 90 within 5 minutes after walking 20 yards. So then we treated him with triple therapy and triple measures. And for some other reason, for a headache, I had to transfer to IDA. And there they did the HRCT maybe 1 week later, and they did the resolving COVID pneumonia. So by that time, the patient was not desaturating, and on the discharge card, they have done the desaturation test, and it was negative mentioned. So meaning, out of these 100 patients, there will maybe 1 or 2 patients that we might miss. The patients who are having this initial fever, cough, shortness of breath, and undue, you know, sick feeling, they complain that sort of a thing, and plus and mind you, as I always say, this is not only a respiratory disease, this is a multi-system disorder, right? So that patient's D-dimer was high, more than 1,000. So, and he threw up MI as well on top of. So this is, again, we can very well explain with the hypoxia-driven mechanism. So when there's hypoxia there, your immune system goes down. If you're having a critical stenosis, you can throw up an MI. So if all the systems are getting depressed on top of this various pathophysiological mechanisms, which yet nobody has clearly described. We only know in and out about the lung involvement, and multi-system other involvements are also very well described. Right. So it is essential that we need to keep these very few patients, not like the previous third wave. They are seeing less numbers, but when the test Omicron numbers are going up, even 1% of 100 patient may be 1, but if 1% of 10,000 patient may be 100 patients. So meaning there is a chance of our hospitals getting overburdened with severe patients if the numbers are going up, even with the less virulent, they say, the Omicron variant. So and again sorry, we can't offer them the rat test as we like. But what we can do is, if they are complaining of this shortness of breath, pain, that sort of things, keep them under observation for desaturation. At least we should be vigilant to check the saturation without taking them lightly. And if they, and even that's one thing. The second thing, the advice per se, even at home, what we have seen is that even though they have this fever, cough, shortness of breath, and exertional shortness, sorry, I'm getting calls and I'm getting interrupted. Sorry. So what we can, so even after getting admitted, so what we advise them is that to get, during the initial viral prodrome and initial sorry, sorry for the interruption. So what we do is we advise them to have a proper rest, meaning do not exert, overexert as a needed, so they can do their daily activities. That's fine, but without getting overexerted, and get them hydrated properly and proper nutrition. So those three things with rest, so their symptoms improve drastically. And out of these patients, their post-COVID symptom severity is also very much less. Whatever, what we can say is that patients under observation, even at home, right? Fever, cough, shortness, mild shortness, still we can manage. But if their shortness of breath is getting more, and if they can't, they find it difficult to walk up to the toilet and come back, or if they need to get their saturation checked, and if admission. Proper adequate hydration. So there, whether it is dengue or whether it is
Sorry, again, there's a background disturbance. Sorry, Dr. Mahendra. Dr. Ishanta Vijayanayaka, can you mute your mic, please? We are unable to mute mics from our end because there's a host issue. Can you mute your mic, please? Sorry, Dr. Mahendra, over to you.
Yeah. So the advice to these patients, especially home-based patients, first we need to ask what we have been doing all throughout, identify the red flags, and refer each patient to the hospital and to get their disease further evaluated. But for home-based patients, I think if the fever is continuing more than 48 hours, 72 hours, I mean, because of the dengue risk, it warrants a full blood count. But during this initial 4 to 7 days, it is essential that they get an adequate bed rest, right? Without overexerting themselves during the, even if it is dengue, if you overexert during first few days, your symptom, your malaise and post dengue syndrome tend to drag longer. So same here, right? So adequate rest, hydration, and nutrition. And after 5, 6, 7 days, what we have seen is that even the admitted patients, they are fit to go. And they don't, so sometimes, they are cough, and sometimes, even after 10 days, 12 days, they come with a cough. And today also, I got a medical student coming with after 10 days, coming with cough and some sense of tight chest, but we did the desaturation, nothing. So there's nothing. But main thing, we should not underestimate the need for checking the saturation of the needed patients, especially hospital admitted patients. Sometimes, we tend to relax, saying that, now the symptom profile is less and we don't need to look into that. The second thing, there's a collateral damage due to COVID. So that we saw in the first wave, second wave, third wave, and it can happen more in the third wave. The meaning, the collateral damage meaning, the patients who are with, especially the diabetics, are more prone, as everybody agrees, and the other comorbidities. So I have seen patients who, even with cardiology and other disease follow-up patients, they have not been seen by a medical clinic doctor for more than 8-10 months. Sometimes the patients are coming with COVID and very uncontrolled diabetes. Their sugars are high in there. right? So that comorbidities are also not getting managed properly because of the COVID. So, and people can die, people can get more complications because of the worsening of their comorbidities. So that can happen with this much of cases are increasing. So that we need to, even with the admitted patient, I mean, sometimes it's very sad that because of a lot of limitations and a lot of barriers, we are sometimes very few occasions we are unable to provide the appropriate care, especially the operations are maybe may get delayed or their routine care may get delayed. Sometimes they may not. Sometimes the patients are with off drugs, and so we got a patient. I mean, not only one patient, everybody. So those patients also, when you get a call from the community, I think other than the COVID red flag, we need to, I think, look into their other medical background as well. Whether they are diabetic, whether they are how to control, whether they are on proper treatment, whether they have adequate supply drugs. I think manage. I don't know, sir, whether that is possible. I think that is what is more needed at this point, because COVID per se may be a lesser virulent variant, but because of COVID, the colorectal damage may be high. So I think as a team, 2417, we can adjust with them as well, and we can do the appropriate referrals. Even though they are mildly COVID asymptomatic, sometimes if you ask, they may not have got their blood sugar checked for ages, and they may not be having their ischemic heart disease aspirin stock at home. So they can get. So that all comes under COVID umbrella. Because of COVID, those things are getting neglected. And the other thing, because of the COVID, sometimes the discharge patients even sometimes they might call.
Your voice is not very clear, Mahendra. Again.
Sorry, sir. So again, the other group is that even after getting treated, the COVID patients sometimes we are discharging them with higher doses of sometimes anti hypoglycemics. Sorry, hypoglycemic drugs, and sometimes so I've got one or two patients, not many, but they came with hypoglycemia after getting discharged. Meaning, what happened was that during the hospital stay, they have been given steroids. Because of steroids, their sugar went up, and we had to increase the hypoglycemic drugs plus the insulin dose, and they have been discharged on a certain course of a steroid form, 1 or 2 weeks or maybe 3 weeks. But sometimes we forget to advise them on the importance of taking the sugar. So once the steroid is stopped, your sugar tend to come down, and your drugs may be more acting now. So 1 or 2 patients I saw with hypoglycemia, and clearly we can see their notes that their drugs have been increased during the hospital stay, and they have been not been advised to get their sugar checked after the steroid course and get their sugar readjusted and their drugs readjusted. So that sort of things also, I mean, we need to look into. So now it's time to manage them. It as a fever syndrome initially and home based, and admit them with the most needed patients, and to look into their other medical issues. Usually diabetes, hypertension, ischemic heart disease, stroke, and a lot of cancer patients, a lot of other surgical patients, things must have got, they can get delayed because of COVID and the panic it created during the third wave. But I hope not, that will not happen during the Omicron stage with the increasing numbers. Yeah, thank you, sir.
Thank you, Dr. Mahendra. I think you have given three very important messages. The first message, very important for all the volunteers at 247. At this situation, treat this as a syndromic condition and advise on the importance of good rest, hydration, nutrition, and ventilation very early on, and probably that would lead to maybe a better prognosis. That's your first message. And secondly, the importance of measurement of saturation and the desaturation test at the admission level. And thirdly, the management of patients with comorbidities and the collateral damage that can happen. So three very important messages we have got from you. Thank you very much, Dr. Mahendra. So let's move into Dr. Asha Samaranayake, because at this time we are at the current situation and not seeing a lot of upper respiratory type of complaints, also sore throat and cough and maybe and even early wheezing and things like that. So Dr. Asha Samaranayake, as a respiratory physician, what are your suggestions? What are your advices for the volunteers at 247?
Yes, sir. Thank you again for this invitation. Sorry, Can you hear me now? Yes, sir.
We can hear you.
Now
Dr.
about
maybe if you
our
can,
patients who are coming from the community, who are calling 247 help. As we all discuss now, better to do like this. I think firstly,
Dr. Asha, is not very clear.
Vaccinated or incompletely vaccinated, or people with multiple comorbidities, as Dr. Mahendra mentioned, poorly controlled diabetes, ischemic heart disease, and so on. For these patients, we should be very mindful whether they are going to have a mild course or not at the beginning. When they come with cough, actually they say the Omicron virus behave a little bit different than the other strains. They have mainly upper respiratory tract, severe sore throat. Some are telling that it's like a burning sensation to their nostrils and the throat. And also they have very, compared to the previous strains, the anosmia rate and the anosmia, the loss of olfactory sense is not much affected in Omicron. The studies in the UK have shown 1 in 5 compared to that of the Delta variant. However, this in the British strain and the Omicron, the Delta strain, we have identified 3 phases in the pathophysiology, as we remember, that is initial viremic phase followed by lung phase and then the hypoimmune phase. Roughly, we divided these periods by 1 week intervals. However, as we already discussed, it seems that Omicron is behaving very strangely, in the sense these phases are not allocated to 1 week now. It's like lung phase is coming early. Even the whole of the illness may last 3 or 4 days if it is relatively asymptomatic. So this virus is rapidly acting and very contagious. That's, of course, we can say from the behavior. And when the patient get symptoms like sore throat, and they may have very loud cough, that is unpreventable. We all may have experience in our life, like laryngitis, so something like pharyngitis, where we will usually get a very loud cough, and this may be troubling the patient. Also, compared to Delta strain and other British strains, Omicron virus seems to produce bronchospasms or wheezing earlier than those old strains. They may present with chest tightness to you in your practice or in the hospital. May not complain that patient has exposures, because the others, their contacts may be asymptomatic. And also remember, they can have difficulty in breathing due to other reasons, especially this high risk group. we should be very mindful, especially our volunteers who may have less experience in clinical still. Remember that when patient complains, high-risk patient complain difficulty in breathing, you have to think about few things, whether this is going to be lung or respiratory thing like bronchospasms or COVID pneumonia, or whether this is cardiac like myocarditis or myocardial infarctions, or else whether this is going to be sort of dehydrated dilation acidosis. That was also we have seen in critical state of other COVID variants, not with Omicron. And also we have seen some patients who are coming with difficulty in breathing. All the evaluations are normal. However, they feel fatigue. Maybe fatigability also added to their exhaustion of difficulty in breathing. So when patients come with difficulty in breathing, with chest tightness, if they have wheezing sound, or they can say that when they are experiencing this sounds like a musical tone is coming, what we ask in Sinhala is Ranum Sadda. If they say yes, you can assume that is wheezing and manage at home with ideally with the budesonide containing inhaler, which is available is a formoterol budesonide combination in our practice. And then it can be given as a dry powder capsule or a meter dose inhaler with a spacer. And then about the chest tightness persisting with some vagus symptoms, always think it as a red flag sign. You have to direct that patient to the admission for further evaluation. I think that is what I have to say about this.
Yeah, thank you, Dr. Asha. Now, regarding this frequent symptom of cough, what do you think about simple home remedies like, say, avoiding of full throat clearance and maybe taking fluid intake and things like that? What are your recommendations on that time in the initial phase in managing if it is troublesome at home?
Yes, actually, we can ask them to get aliquots of water to prevent the dryness of the throat. That's of course true. However, something like lemon lintex and so on, but we are not usually practicing those in our Western medicine. Some are asking about the steam inhalation. Of course, this is being already a very contagious virus. It can spread the virus for further away in the household. So we cannot advise it is as a safe procedure. And some are using very high heat to the steam inhalation, thinking that they can kill the virus in their throat. However, for the mild cough, they can use some non-sedative antihistamines like loratadine, desloratadine, or something like more advanced ones, flexofenadine or rupatadine. Rupatadine was studied in some general practice. Actually, they are never non-sedative antihistamines. But they may not change the natural history of illness. This is for the symptomatic relief. For the loud cough, of course, with nasal congestion, we may give some nasal wash to the nose, some commercial preparations or sterile nasal drops. I'm not recommending any steroid use. Actually, I had to tell that from the beginning. Don't use steroids in the first phase of the illness, because it is the preventive aspect of the illness. So the further deterioration is depend on one's immunity. We should not blunt the immunity of the patient. Like when the patient develop acute exhibition of asthma, we usually give steroids as the mainstay of management. But I think we have to wait until substantial duration, like at least 5 days is gone, to start steroid course in asthma exacerbation. Anything else, sir?
Yeah, I think, Dr. Asha, I think we have covered a lot of general questions. But of course, from the audience, I mean, there may be questions that or the situation that you experience now. We have heard a lot about the general measures and even about steam inhalation and things like that, which patients very frequently ask from us. Any
Yes.
questions from the audience? You can send from the chat. And meanwhile, we'll move into the next other questions. There are a lot of questions related to vaccination also, now immunization, vaccination. And it was very much highlighted, almost unanimously highlighted the importance of fully vaccination. Now, yesterday also there was a circular release, and there's a lot of confusion or maybe kind of unclearness regarding certain areas. And for example, now the guideline regarding vaccination after infection, the booster dose, initially it was 6 months, now it was changed to 1 month, and there is some unclearness about regarding vaccination of children, and then when to get the vaccination if they get infected, and also vaccination of during pregnancy. Those areas I would like to hear the viewpoint of Dr. Shirani Chandrasri and Professor Neelika Malavike. Shirani, would you like to go first and then followed by Neelika?
Okay, Indika. Yesterday's circular did not change the frequency, but earlier we were giving the whatever the vaccine after any COVID positive patient after 6 months, but this was brought down to 1 month. So now any child or adult after being positive either by PCR or RAT or onset of symptoms after 1 month, they can get the booster dose. Other than that, it did not change any vaccination decisions. Yesterday's circular, it mainly dealt with the isolation period, quarantine period, contexts like that. At the moment, 12 to 15-year age group gets 1 vaccine. 15 to 19, they can get 2 doses. From 20 years upward, to say fully vaccinated, you need 2 doses of Sinopharm or Covishield or Pfizer or Moderna, followed by booster dose of Pfizer that is given 3 months after. These actually, even the dose is 2 weeks after the dose only, you are considered fully vaccinated because it takes 2 weeks to develop the immunity. So the adult who are fully vaccinated now actually don't need to quarantine if they are exposed to, if they are considered as a first contact. That was the most important change I see in yesterday's circular. And other than that, after 7 days, even the patients can be released if they are without fever for 48 hours without any antibiotics. So vaccination guidelines have not changed. Only if patient is COVID positive, the time again, I mean, it was earlier also 1 month after the disease, then it was 6 months. Now again, it's 1 month after being COVID positive. Pregnancy, we are vaccinating. Actually, earlier, vaccine was not offered to the pregnant ladies, but all over the world, there were a cohort of females who got vaccine without knowing that they are pregnant. These ladies were followed up and safety was established, and now it's accepted that you can safely get the vaccination during pregnancy. I would like to encourage all the pregnant females to get the vaccine, because I have seen 2 maternal deaths. When you get severe COVID pneumonia, it's very difficult to manage with pregnancy, even though the baby was delivered by cesarean section, we could not save those 2 patients. So vaccinated females will have a much better chance to face the infection if they have the immunity. Those are the things I want to stress, and I think Neelika can explain the immune response and the decisions. Thank you.
Right, thank you, Shirani. I can't see Neelika. Maybe she might have left.
Professor Neelika informed that she has another meeting and she left.
Yeah.
Yes.
Maybe if we can clarify others also from Dr. Shirani, I mean, that would be, so you have summarized it, the circulars that were coming. So essentially the vaccination, the schedule hasn't changed other than the change from 6 months to 1 month for those who have been infected. And then another question, maybe now there are some who, for the travel requirements, who want to go abroad and they might need vaccination according to those countries. Are there any arrangement for those, or they have to take it from maybe say like the different other establishments? Dr. Shirani.
In the still it is to the army portal where they register
Okay.
and
Yeah.
get the vaccine.
Yeah.
That vaccines are not offered through hospitals.
Exactly. Yeah. And
Yeah.
and maybe
Can I come in, please?
yes, yeah, please,
Yeah.
Dr. Abhidhamini.
Yes. Now, Sinopharm 2 doses and the boost of Pfizer given, but according to the Australian immigration guidelines, Sinopharm is not accepted. So what can a person do there? There was a man who, when want to go to Australia, he was turned back at the airport here, saying that having had 2 Sinopharms plus Pfizer booster is not acceptable to the Australian immigration people. What can you do in a situation like that? Because most of our people have had the Sinopharm 2 doses. Yes, that is my question. Hello?
They have to get registered. I mean, you have to check the country's requirement where you are planning to visit, sir. Then they have to register in the army portal for that type of people.
Yeah, sorry. It is given on the website, Australian website. That's they have given 4 types of vaccines that are recognized. You know, Sinovac is there, but not Sinopharm. Then, of course, Indian preparations, both that Bharat immune that thing, and of course, what it is, Pfizer. Those are the things that are definitely Sinopharm is not there. Now, this is a person who has had 2 Sinopharms and booster of Pfizer. He was turned back at the airport 2 days ago, saying that no, you can't go there. Now, this is the solution I was thinking. Now he has had a booster of Pfizer. Let him have a second Pfizer in 1 month. So will that be okay? Will it be considered as
But the thing is, offering it like that from government institutions is difficult because of the circular. We can give it Pfizer as 3rd dose.
Yeah, I know. So how? So there is no solution we can give to this person.
Probably, sir. I mean, those actually depend on the host country requirements. One option may be like Shirani mentioned, now the army portal. I mean, they are basically registering, and there is another option where if there is a DGHS approves, then the vaccines can be obtained from the army vaccination program. That could be one option for those, because they will be issuing vaccines only based on the DGHS recommendation. So maybe the epidemiology unit or the government vaccination program, I think the options at the moment may be limited, but probably one option could be a letter from the DG to them, to the army vaccination program for specific requirements. I'm not sure whether those different country requirements are at the moment catered in that way.
The thing that will be, I mean, there may be so many. I mean, going to Australia, so many people go, and most of them had the Sinopharm. So getting letters from the DG may not be all that practical. Anyway, we'll have to see. I don't know what they asked me for advice, so I said, why not try and get a 2nd dose of Pfizer? I don't know. They didn't ask me where they could try, but that was the only suggestion I could give. Okay, thank you. Right.
And another question again, maybe from Dr. Shirani. Now, again, this regarding the change guideline, yesterday's change guideline. Now, the fully vaccinated, those are fully vaccinated. Now, they are released from the requirements from quarantine also. What are your comments on that? I mean, because even the fully vaccinated can get the infection and they can spread the disease. Any justification or your comment regarding this?
Indika, I agree that even the fully vaccinated can get infection. But the thing is, even all over the world, they have reduced the number of days for quarantine and things because now the disease is mild. I mean, most people with a vaccine, especially Omicron gives mild disease. So these decisions were taken after discussing with clinicians and looking at the international guidelines. I think it's a good decision because if we continue to keep people for 14 days, we will not have workforce for hospitals, because when it spreads fast in the community, our staff is part of the community and they also get sick.
Yeah. I think, I also tend to agree with you, Shirani, because at the moment we need the compliance of the people also and the empowerment. So in that way, and since because of vaccination, now the whole situation has changed and probably the duration of the disease and everything has changed. So in that way, it could be a good move to reduce the number of days so that you can reduce the spread at the same time while maintaining the service component as well and also the compliance of the patient. So yes, in that way, I think probably the yesterday's guideline in that way was a positive thing, and that would ensure better compliance, and maybe we can adhere to that and empower the people. So how they can basically self-isolate or self-quarantine based on the new regulations. What do you think?
Yes, Indika, and the incubation actually is shorter. I mean, earlier we were seeing it manifesting even late as 10 days, but now most are within first 7 days manifesting the illness.
Thank you. I think now we are coming close to the end of this session. Before we conclude, I would like to ask from Dr. Anthony Mendes, what is the symptom profile? Say now, when we talk about red flags and early identification of red flags and then detection and early referral. So what is your experience? What kind of profile that you get there at the intensive care level? Dr. Anthony Mendes, are you there? Can you hear?
He's there, sir, but the mic is muted.
Mic is muted. Okay. Yeah. So I think today now we have come to the conclusion, and we have discussed many areas related to the disease, and then the new changes, symptom profile, and also the changes in guidelines and how we can adhere to that, and a lot of important information for 247 volunteers. And probably we will summarize all this information, and some information we'll try to simplify as in the form of a flow chart as well. Now I would like to invite my co-host Dr. Sajith Edirisinghe and also Dr. BJC Pereira to sum up the session and conclude. Over to you, Dr. Sajith and Dr. BJC Pereira.
Thank you, sir. So thank you very much, everyone, especially the resource persons, despite of your busy schedules, participating with us and share your expert knowledge with the 247 doc call 247. The volunteers and the other participants, the media. I know there were media people here. So we, as SLMA and SLMA 247, we just want to share the correct knowledge to the society. I think we have done that task. And thank you very much again, despite of your very busy schedules, coming and sharing your knowledge and educating us. Because this is a telemedicine exercise, which is starting from the emeritus professor level to the junior most medical student. So everyone come as a team and help us in this telemedicine exercise in the 247. So thank you very much again. Over to you, BGC sir.
Yes, thank you very much, Indika and Sajid. I'm a little bit concerned about something which really is not probably directly related, because this particular program was, I believe, designed for those who are actually involved with the doc call 247. But I think something that is quite important is that the real picture is not being conveyed to the public, and most of the speakers actually made it very clear that the chances of getting a major complication and dying of COVID is reduced very significantly by proper vaccination and by the booster. Now, this has not been conveyed to the public in that particular way, that it would save lives. And you find MLTs and PHIs coming sometimes on the media and really giving rather dubious bits of advice, and also basically all the time complaining against the government and putting the blame on them for the spread of the disease. I think it's very important, and I'm also concerned that from the time that this particular problem with the Omicron started, that the SLMA has been rather dormant as far as dissemination of information is concerned. I think now today I can't see Professor Samat Dharmarathan, the current president, but I think we should really tell everybody that who are involved, and especially the office bearers of the SLMA, that it's time that we had a couple of press conferences and made the position quite clear to the press, so that the media, so that the proper information is conveyed to the public. SLMA was practically a household name or acronym just right up to just about a month ago. But we haven't heard anything from the SLMA. And in fact, in a news broadcast, I think either yesterday or day before, I think it was yesterday, or day before, that a trade union representative was featured as from the SLMA. I don't know whether anybody noticed this. So it is giving all the wrong information. So I think what I would like to see is a proper medium of conveying all this information, and also to release a press statement on the importance of the vaccination program for the general public and for the benefit of society as we see it now. Thank you very much.
Thank you, sir. And I think we have shared a lot of valuable information, valuable advices, and there are a lot of suggestions coming from the chat also, and we'll try to summarize some of those suggestions and incorporate it into our program. And we are looking forward to all your support to the SLMA 247 program. And Dr. Mahendra Ekanayaka, would you want to make any comments? Yes, you are welcome.
Yes, sorry to taking another 2 minutes again. Now regarding the cough with not only COVID, any other viral illness, I just wanted to, I know that there's a very expert senior consultants are there, and we are practicing Western medicine, right? I just wanted to share my personal experience I had when I was doing my foreign training in Australia. I worked in one of the busiest emergency departments, So, and when I went there, so I mean, for the patients with cough, so I started writing, searching for cough syrups and writing short courses of steroids and these Derifilin like stuff initially, first 1 or 2 days, and then to tell you all frankly, then the director, emergency director, just came to have a chat with me, and he explained the evidence based treatment of cough to me, and out of that discussion, what he said was that only evidence, some evidence only, there may be pharmacologists also here and senior, with all due respect. He said the only evidence is that we have honey lemon tablet is the only evidence. Some evidence is there, and if you want to give some treatment for cough, there are some honey lemon tablets in the emergency department. Grab one and give it to the patient. Actually, I went there to the. We can go inside the drugstore and with our swipe card, and I searched for it. And I have some of the. Still, I have some tablets with me after a very long time. So, and they had 2 treatment modalities. One thing is they give that's over the counter honey lemon tablet. And the good old days, we used to take honey lemon for cough and all as well. The second thing they gave us there in the emergency department, there is another tablet. I will only read the generic name of that: benzdiazepine hydrochloride 3 milligram. So it comes under a Diflam or some trade name. So what this tablet does is that it's some sort of it contains aspartame as well, some sweet taste, plus it causes some mild anesthetic like sensation to the throat, and your cough is very well, symptomatic. Mind you, it is only a symptomatic treatment. So those are the only 2 treatments that they recommend. And to add further, when I went through one of the NIH's UK guidelines regarding the COVID symptomatic treatment, and I think you all can find that guideline in the internet, and under the treatment of cough for symptomatic relief, surprise, they recommend honey. And I discussed this in the SILSIM, our Internal Medicine Society, one of the discussions as well with seniors. So honey is, NIH's guideline, it is there as symptomatic treatment for cough. So, but we as Western practitioners, what we should send them is that honey is not a cure for COVID. That is what the other quacks are misleading. So you can get a symptomatic relief, maybe temporary relief for this irritating cough if you take honey and if you take lemon, but it doesn't cause disease cure. So initial stages, if you can remember during the first wave, when the tests were, these rapid tests were not widely used, they used clinical improvement, symptomatic improvement as a marker of disease cure, initial stages, 1 or 2 years back. So that may be the reason why some of the people thought that, after taking honey-based things, this disease is getting cured. But NIH's guidelines, it clearly says it is only a symptomatic relief. And I don't know whether as Western practitioners, we can recommend honey. And actually I use sometimes, because it's there in the UK Suddha's guidelines. So why not? You can give honey, or else
Mahendra?
There are some. Yes, madam.
When
There
we
are
were
some
kids,
honey lemon tablets.
Sukiriovalmi.
Yes.
When we were kids, we were given Sukiriovalmi.
Yes, I think, madam. No, still we are Sri Lankans, and we can, only the good message what we can send them is this is only a symptomatic relief, and even the steroids and everything, we can save a lot of people by not prescribing steroids and unnecessary antibiotics for these coughs and sore throats. One is that benzdiazepine hydrochloride is very good, effective. It comes in sprays and it comes in tablet form as well. I don't know whether it is available in Sri Lanka. I never bothered to look into that. But I know that there are some honey lemon tablets available over the counter, or just simple Pirisidu mee penny and some lemon or Sukiri Valmi. I mean, whatever. I don't know whether as SLMA we can recommend. It's over to you, Indika sir. I mean, I think we need to get some senior consultants' opinion on that as well before shouting it out to the community.
Yeah,
Dr.
Mahendra, I think
NIH's guideline.
Yeah, I think it's at home relief, home treatment, or home remedy, because now today it was very clearly highlighted. The most important thing is that many get mild symptoms, and if you start early management, like early rest and then good rest, hydration, nutrition, and basic symptomatic management, probably many would be okay, provided we maintain a low threshold for any kind of, say, red flags. Then I think 247 actually can do a huge service through community empowerment. So scientifically also, I honestly don't see anything wrong about advising patients about those simple measures, what we have mentioned. Because I mean, scientifically also, it has been proven to be of symptomatic value. And also at this situation where the patients are facing many practical difficulties on going to pharmacies or finding drugs, in this situation, I mean, the message that we have been giving right throughout at 247 are the very simple measures that you can follow at home. And if they need any medication that is more than that, probably they are in a situation that they need the urgent or the hospital intervention. So in that case, there's definitely room for basically adopting the simple practices that are scientifically proven. Before we conclude, maybe, I mean, if I can get the viewpoint of maybe Dr. B.J.C. Pereira and maybe Dr. Antoinette, Professor Antoinette, or Dr. Sarath Gamini regarding what Dr. Mahendra was mentioning.
Yes, Indika, I think what you said was quite reasonable, because this is a home remedy and you don't need permission from anyone else to give. This is the kind of home remedy that is being used, and it has been used for quite a number of even decades in Sri Lanka as well. So I don't see any problem about advising the patients to use, because we don't have proprietary preparations of these kind of combinations of, say, lemon and honey and things like that. We'll have to tell them to just make it up at home and take it. I really see no problem with that.
Yeah, my issue is, excuse me, my issue is that, by advising, are we giving some...
We can't hear you, sir.
Sorry, can you hear? Hello. Can you hear me, sir?
Very faint.
We can hear, yeah.
Yeah, my issue is that, why advising them to take honey, are we giving some undue recognition for those penny carriers?
No.
Like, there are so many other pennies, they are selling in the country. That's my fear. Yes, sir.
I think Dr. Sarath Gamini and
yes.
Professor Antoinette Pereira want to comment. Yes.
As for cough syrups, right along, we knew that it's not a curative thing, it's symptomatic relief. For a person with dry cough, which is really distressing, we use codeine containing syrups, which is very effective in suppressing a cough. So I think quite a lot of our patients get symptomatically better by just swallowing a syrup, all right? I mean, there is a risk of what this physician said, that by recommending syrup, they will go to the Ammika penny and all kinds of things, but we have to, there is a limit to which we can safeguard against those. But if we know that any antihistamine containing syrup makes the patient feel better rather than swallowing the antihistamine tablet, I think that's okay. That's okay. Right, that's all.
Professor Antoinette Pereira also, madam, if you want to make any comments before we conclude.
I have one question. The children, this about honey and comment about bees honey and ambuldodang and red onions and sugar and all are things that are used as home remedies. People use it and they know it is for symptomatic relief. I don't think they'll start using Dhammika penny and things because we tell them to use this. And if we only tell them it's for the distressing cough, they are happy when they, like Sarath Gamini said, they are happy when they have something to take, in the form of syrup or whatever. That is one. The other thing is, now the children, we are seeing children getting very minor illness. Generally under 5 are the people who get pneumonia and die. That is what, BJC and I did a study on it at one time. So now this is very mild in the children, the present COVID. And what is the reason? What is protecting them? There was a talk about BCG. I'm just curious about it. Now they are not vaccinated. We are saying get vaccinated for the adults and the older children. But the smaller children are having very minor illness. It lasts about 24 hours, maximum 48 hours. So what is protecting them? Can somebody answer my question?
I think the simple answer, Internet, is that we really do not know. I think probably you can speculate on very many different things, that the immune system, which is probably at a given age, like in very young children, it may be quite active, and also it may have been stimulated by various other viruses as well. So you have both the humoral as well as the cell-mediated components of it, probably a little bit more primed in the children under 5 years of age, probably by cross-infections with other viruses. I mean, again, very much speculative. I don't know. But
no, even children who are about 1.5 months, 2-3 months, they are having very mild illness.
Yes, but then we really don't know the real answer to this actually. But these are all speculations. And I think there was some work done on the ways some people, there is a difference in the antibody response of people who get, there is some difference in some of the studies in those who get mild illness when compared to those who get more severe illness. But I think this entire picture has been, I'm not talking of children, but the adults, the entire picture has now been changed by the vaccination. But as for the children, Internet, I really don't know, because as you quite rightly said, that we know that in any respiratory problem, the highest mortality is really in the under 5-year-olds, and of course more so in the under 2-year-olds.
The other thing is, should we watch these children for about 10 days? Whether they are, because it's now the sort of, we are now getting children who are acutely ill and recovering.
Yes, I think there is another thing about this, what I mentioned at the start about Miss C, because that is a delayed response. So the very few, it's pretty rare, and those who get it can only be detected by keeping them under observation. But of course, there are certain signs like abdominal pain, skin rashes, lymphadenopathy, and red eyes. Those are the real red flag signs for them. But if they develop that at any time within a month, basically, of the initial illness, I think they should go immediately to a medical facility.
I think that has to be
Thank you, sir,
given
and
to
thank
all
you, madam.
247 people. Right. Okay. Thank you.
Yeah. So, thank you very much for all these observations. I think now we have come to the end of this very important session, and the messages, I think, was loud and clear. There is increase in number of patients, and most are milder, and the disease duration probably has become shorter, but at the same time, we cannot ignore the possibility of some number going into critical conditions, and mostly who have comorbidities and also who haven't completed vaccinations. So the importance of vaccination, also the booster was highlighted, and the new guidelines, how they have been shortened based on the vaccination status and the current situation of the country. So we have got very clear messages, and from 247, so we expect and invite all of you to support this valuable service at this very critical moment. And again, what we should be doing is again very simple and clear. Support the people, support the patients, empower them and develop their capacity. Very simple measures like advices on reassuring them. Most of them are very confused and very nervous. Reassuring and helping them and responding to their calls, and also simple advices like resting, hydration, nutrition, ventilation, importance of vaccination and how to get vaccination. And at the same time, not forgetting to keep an eye on the possible red flags, and then immediate referral to the required departments or sections. So all these messages, a simple message that we have been following. So let's work together and help the country at this very critical moment, because I think 247 can do a huge contribution for the country at this moment and to settle this situation. Thank you very much. And with that, we'll be concluding. And I thank everyone, all the resource persons, SLMA, Mobitel, and all the participants for their contribution. Thank you. And
Indika, one last word.
Yes.
I think we should also send a message, a clear message to the hierarchy of the SLMA to respond properly with a press release or a media seminar or whatever, to put things in their perspective, because people are running around saying that, oh, it's very mild and things like that. They don't realize exactly what can go wrong.
Yeah.
So I think we have to tell the hierarchy now.
Exactly. Actually, sir, today's discussion is so valuable. If you can summarize the main points, that would be a wonderful message that we can
That would be
send to
enough.
the community. Yes. Yeah. So let's work on that.
Okay.
Thank you very much. And with that, we'll be concluding, and have a great evening and stay safe.
And you too. Thank you.